Hello and welcome to Inside Ophthalmology. I am Dr. Amrit and I welcome you to second module of our IOL series, the IOL Design Basics. In this module, we'll build the foundation needed to understand why different IOL designs behave differently inside the eye even when their labeled power is same. A basic intraocular lens has two components, the optic and the haptics. The optic is the transparent central part of the lens. Its job is simple, to refract incoming light and focus it onto the retina. The haptics are the peripheral extensions of the optic and they fix the IOL to the surrounding ocular structures, providing stability and centration within the capsular bag. In simple terms, the optic does the seeing and the haptics do the holding. The average capsular bag diameter is about 10.4 millimeters. The haptic to haptic diameter of most IOLs is about 13 millimeters, intentionally oversized. This intentional oversizing causes the haptics to behave like springs, exerting outward centrifugal force against the equator of the capsular bag. This outward tension is what keeps the optic well centered along the visual axis. After the cataract surgery, the capsular bag also undergoes fibrosis and centripetal contraction naturally. A properly sized haptic system provides mechanical resistance to this contraction. If the haptics are undersized or too soft, the capsular contraction can result in anterior capsular phimosis, zonular stress or rupture, and even late IOL decentrations or dislocation. The optic diameter is usually about 6 millimeters, optimized to provide adequate visual coverage and minimize the edge effects and glare. To understand the IOL behavior, we must first ask a fundamental question. How do we model the eye optically? After cataract surgery, the eye becomes a two-lens optical system. The cornea, which we retain, the intraocular lens, which replaces the crystalline lens. How we model these two elements determine how we define and predict the optical outcomes. This brings us to the distinction between the thin lens model and the thick lens model. In the thin lens model, both the cornea and the IOL are assumed to have negligible thickness. Each element is treated as if it refracts the light from a single plane. This greatly simplifies the calculation. In this model, the effective lens position is simply the distance between the cornea and the IOL and is usually measured from the corneal vertex to the anterior surface of the IOL. If ELP changes here, the assumption is straightforward. The lens has physically moved backwards or forward. The problem here is obvious. The cornea is not thin. The IOL also is not thin in reality. Both of them have thickness, they have anterior and posterior surfaces, curvature, and unequal power distribution. When we treat a thick optical element as thin, we lose the geometric information and that loss translates directly into the loss of refractive precision. This limitation is why the thin lens assumptions eventually fail. In the thick lens model, we treat the cornea and the IOL as they truly are. The optical elements with thickness, with anterior and posterior refracting surfaces. Analyzing such systems directly is complex, so optics uses a powerful simplification tool. And what is that? That is the principal plane. Principal planes are theoretical reference planes that allow us to replace a thick lens with an equivalent thin lens that behaves identically from an optical standpoint. In simple terms, lenses do not act from their surfaces, they act from their principal planes. The position of these planes will depend upon the lens thickness, the curvature of the anterior surface, curvature of the posterior surface, and the distribution of the optical power. Change the geometry and the principal planes will shift, even if the lens has not moved anatomically. Remember that. In a thick lens model, ELP is the distance between the principal image plane of the cornea and the principal object plane of the IOL. This is the key insight. ELP is an optical concept and not purely an anatomical one. Why this matters? ELP can change in two distinct ways. Anatomical movement of the IOL or the optical design changes without any physical movement. This explains why two IOLs with the same labeled power implanted in the same eye can produce different refractive outcomes if they have two different optical designs. So in summary, in a thin lens model, ELP variation implies basically a physical movement. But in a thick lens model, ELP can change purely due to geometry. This distinction is foundational. Now that we understand principal planes, thick versus thin lens models, and the true meaning of the ELP, we are ready for the central question of the module. How does IOL optic shape alters the effective lens position? Based on the optic geometry, monofocal IOLs can be broadly classified into biconvex, plano-convex or the convex plano, and the meniscus lenses. And each of these alters ELP in their own way without actually moving the lens. Let's start with the biconvex optics, which is the most commonly used modern IOL design. In a biconvex lens, both the anterior and the posterior surfaces are convex, and the optical power is distributed fairly symmetrically across both surfaces. Because of this symmetry, the principal plane lies close to the center of the optic. As a result, the optical effective lens position closely matches the anatomical position of the IOL within the capsular bag. This is a key reason why biconvex IOLs are so reliable clinically. They produce highly predictable refractive outcomes, they work well with the standard third and fourth generation formulas, and most importantly, they show minimal variation in A constant across the power ranges. Since the principal plane barely shifts as power changes, the effective lens position remains stable and the refractive surprises are also uncommon here. This is why biconvex IOLs are the default workhorse design in the modern IOL surgeries. Now let's move to the asymmetric optics. Here we have the plano-convex and the convex plano lenses. Here most of the refractive power is concentrated on one surface while the opposite surface is flat. This asymmetry shifts where the lens optically acts from, even though the IOL has not moved anatomically. This table is extremely important and also the most common source of ELP confusion. In a plano-convex design, the posterior surface is convex, so most of the refractive power lies posteriorly. Because of this geometry, the principal plane shifts posteriorly, so optically the lens behaves as if it is sitting further back in the eye. This means that the effective lens position becomes slightly longer and each diopter behaves now slightly weaker. Okay, so if the power is not adjusted, this results in a hyperopic surprise. Clinically, this is compensated by implanting a slightly higher IOL power. Then the convex plano IOL, in contrast here, the anterior surface is convex and most power lies anteriorly. This shifts the principal plane forward closer to the cornea. So the lens behaves optically as if it is slightly more anterior. The effective lens position is shorter. That means the rays of light now get less time to diverge before they meet the principal plane for refraction. So each diopter here now behaves stronger. There's going to be more convergence per diopter. And if unadjusted, it will lead to a myopic outcome. Again, this is not the purpose of the lens. It's simply what happens if ELP is not accounted for. Fortunately, the modern formulas usually correct for this automatically. Let's explain this diagram. When the effective lens position shifts anteriorly, the lens acts more powerfully per diopter, so the less labeled power is needed. When the effective lens position shifts posteriorly, the lens acts less powerfully per diopter and a higher labeled power is needed. The plano-convex lenses are particularly useful in eyes with permanent silicone oil. The silicone oil alters the refractive behavior. If a standard biconvex IOL is used, the posterior curvature creates a very strong refractive interface between the IOL and the silicone oil. This often produces severe hyperopia, sometimes requiring +4 to +8 diopters of correction. However, a flat posterior surface minimizes this refractive mismatch, making the convex plano IOL the preferred choice in these patients. Also, when we're talking about the advanced lenses, other than the biconvex lenses, orientation is critical. If a plano-convex IOL is inserted upside down, the refractive plane shifts dramatically, often causing an about +2 diopter error. Okay, and this is picked up by the S sign. So what is an S sign? The S sign is a clinical indicator that an intraocular lens has been inserted upside down in the eye. Surgeons use this visual orientation of the haptics, the sidearm of the lens, to ensure that the lens is positioned correctly. When the haptics form the shape of the letter S instead of the intended orientation, the lens basically is flipped. Avoiding this S sign is a fundamental rule of cataract surgery to prevent refractive surprises. Now let's talk about the meniscus IOLs. The meniscus IOLs represent the extreme end of the intraocular lens geometry. Unlike the standard biconvex or the planar convex designs, the meniscus lenses have one surface that is convex and the other concave. This shape is not chosen for cosmetic reason. It is optically mandatory in certain situations, particularly in eyes with high myopia and very long axial lens. In these eyes, the retina lies far posteriorly and the required IOL power is often very low, sometimes even approaching zero or slightly negative. Positive meniscus lenses are the most commonly used variant in high myopia. Here, the anterior surface is convex and the posterior surface is concave, resulting in a low positive net power. The optical consequence of this shape is that there will be a posterior shift of the principal planes, which will effectively lengthen the effective lens position. Each diopter of the lens now behaves more weakly, which is precisely what is needed in a long eye. By reducing the convergence of the light rays, a positive meniscus lens avoids a myopic surprise and allows for a predictable refractive outcome even at a very low power. In contrast, in extremely myopic eye where even a zero diopter positive lens would overcorrect, a negative meniscus lens may be required. In this lens, the anterior surface is concave and the posterior surface is convex, giving the lens a net negative power. Optically, this diverges the light slightly and shifts the effective lens position anteriorly. While this can neutralize the excessive convergence in extreme axial myopia, negative meniscus lenses are highly sensitive to placement. Small errors in centration, tilt, or orientation can produce large refractive surprises, and they are more prone to inducing higher order aberrations as well. Meniscus lenses as such induce higher order aberrations. For this reason, the negative meniscus lenses are rarely used and pretty reserved for very specific cases. Both the meniscus lenses require meticulous surgical techniques, careful planning with advanced IOL calculation formulas such as the Barrett's Universal 2 or AI-based calculators, which can account for these extreme geometries. Before we talk about the aspheric IOLs, we need to understand why spherical aberration even matters. So first, what is spherical aberration? In an ideal optical system, all incoming rays of light should focus at a single point. But in real optics, that doesn't happen. The peripheral rays and the central rays don't focus together. When the peripheral rays focus in front of the central rays, we call it positive spherical aberration. And when the peripheral rays focus behind the central rays, that is the negative spherical aberration. Now here's the key physiological insight. The human cornea naturally has a positive spherical aberration. The cornea is steeper in the center and it gets flatter towards the periphery. That means it has a prolate shape. In young eyes, this isn't a problem because the young crystalline lens has a negative spherical aberration which partially cancels that of the cornea. So this system is balanced, contrast is good, and the image quality also will be high in the younger eyes. Now, as the crystalline lens ages, its spherical aberration shifts from negative towards positive. So now you have a cornea with positive spherical aberration and a lens that is also becoming positive. So the cancellation is lost and the image quality degrades. Now imagine what happens after cataract surgery. If we implant a conventional spherical IOL, the spherical IOL adds positive spherical aberration, further increasing the total ocular spherical aberration. That's why the traditional spherical IOLs tend to reduce contrast sensitivity, especially at the larger pupil sizes seen in the mesopic or scotopic conditions. And yes, as I told you, this is pupil dependent. The larger the pupil, the more peripheral rays can enter the eye and the more spherical aberration starts to matter. This is where the aspheric IOLs come in. So what is an aspheric IOL? An aspheric IOL is designed so that the curvature changes gradually from the center to the periphery instead of having a constant radius like a spherical lens. This asphericity is achieved by making one or both surfaces prolate, meaning flatter in the periphery. Now, different manufacturers do this differently. Some will use an anterior prolate surface, some can use a posterior prolate surface, and some designs incorporate both the surfaces. There are three functional categories of the IOL optics based on the spherical aberration. Number one is the positive spherical aberration IOLs, which are the traditional spherical IOLs. These increase the eye's positive spherical aberration and add up to the spherical aberration of the cornea. They generally provide the worst image quality but the greatest depth of focus. Because of this trade-off, they are rarely used today except in very specific situations. One important indication here is the post-hyperopic LASIK eyes, where the cornea may have developed a negative spherical aberration post-LASIK. In such eyes, adding a positive spherical aberration IOL can restore balance. Then we have the negative spherical aberration IOLs. These lenses are designed to counteract the cornea's positive spherical aberration, and therefore they are going to provide you the best image quality, the best contrast sensitivity, and superior night vision and mesopic performance. But there is a trade-off. They have the least depth of focus, they are highly sensitive to decentration and tilt, and decentration here induces higher order aberrations, especially the coma. Because of this, they require a good capsular support, good centration, and preoperative corneal assessment as well. And therefore, these lenses, that means the aspheric lenses with a negative spherical aberration, are chosen in eyes with no prior corneal surgeries, eyes with normal corneal spherical aberration, and eyes where the image quality is the priority for the patient. The third type of lenses could be the ones with zero spherical aberration. These lenses neither add nor do they subtract the spherical aberration. They offer a good balance of image quality and a reasonable depth of focus. Moreover, they are less sensitive to decentration. This makes them extremely versatile, and they are often preferred when there is a risk of IOL decentration, capsular support may not be perfect, or when the surgeon wants a safe, predictable optical outcome. So remember, the negative spherical aberration IOL gives you the best image quality but the least depth of focus. The positive spherical aberration IOL gives you more depth of focus and a poorer image, but a zero spherical aberration lens will give you a balance of the both. Now that we have discussed the optic design, let's move to the second major structural component of an intraocular lens, that is the haptics. When the optic determines how light is refracted, the haptics determine where the optic stays, and as we have already learned, the positional stability directly influences the effective lens position, tilt, decentration, and visual quality, especially in premium IOLs. Broadly, the IOLs can be classified based on the haptic design into a plate haptic lens and an open loop haptic lens. The plate haptic designs were first introduced with the early foldable silicone IOLs, and they are still used by some manufacturers today. In this design, the optic is supported by broad, flat, plate-like extensions rather than the thin filamentous loops. One important advantage of plate haptics is excellent early postoperative stability. Because of their broad contact area, they resist rotation very effectively, which is why plate haptics designs were initially attractive for toric silicone IOLs. However, the plate haptics have a significant long-term drawback. They interfere with the complete fusion of the anterior and posterior capsule along the axis of this plate, and this leaves a potential space through which the lens epithelial cells can migrate, increasing the risk of posterior capsular opacification. Now, some manufacturers have attempted to improve this design using the modified plate loop hybrids, which allow slightly better adaptability to the capsular bag size variations while maintaining the stability. However, the plate haptics overall have become less popular compared to the open loop designs because of the PCO concerns. Next, we have the open loop haptic IOLs. The most commonly used modern IOLs employ the open loop haptics. These provide better capsular bag conformity, long-term centration, and reduces the capsular stress as well. The open loop IOLs can further be classified into single piece and multi-piece designs. In a single piece IOL, the optic and the haptics are manufactured from the same material, and most commonly it is the hydrophobic acrylic. Because the haptics are flexible and integrated into the optic, these lenses are highly resistant to damage during the injector-based implantation, which makes them suitable for cataract surgery with smaller incisions. This is why most of the injectable IOLs today are single-piece designs. Clinically, the single-piece open-loop IOLs are best suited for in-the-bag implantation. They're not ideal for sulcus placement because their thick haptics can actually cause iris chafing. Next, we have the multi-piece open-loop IOLs. In a multi-piece IOL, the optics and the haptics are made from different materials and then they are assembled together. The optic is commonly acrylic or silicone, while the haptic are commonly made up of PMMA, PVDF, polyamide, elastomide, or polypropylene. Now, these lenses allow more refined haptic architecture and are particularly useful when sulcus placement is anticipated. Based on the loop design, multi-piece IOLs can be classified into a C-loop and a J-loop and a modified J-loop. The C-loop haptics provide a broad symmetrical contact with the capsular bag and are preferred design for in-the-bag placement due to excellent centration and flexibility. Then we have the J-loop haptics, which create a more pointed contact with the capsular bag. And when placed in the bag, they may initially cause some amount of posterior capsular stress folds, which typically resolve within a month. Now, because of their geometry, the J-loop haptics are preferred for sulcus placement where they minimize the iris trauma. There are also modified C-loop and modified J-loop designs often used in 3-piece IOLs, again intended for sulcus fixation. Finally, the IOLs can also be classified based on the material flexibility. We have the rigid or non-foldable IOLs, which are made up of PMMA, and these require 5 to 6 millimeter incision. These are economical but surgically less convenient. Then there are foldable IOLs, which are made up of silicone, hydrophobic acrylic, hydrophilic acrylic, and these allow small incision surgeries. We also have rollable IOLs, which are made up of ultra-thin hydrogel lenses, and these IOLs can be rolled and injected through micro incisions. Flexible IOLs are delivered using the injector system, which minimizes the contact with the ocular surface and reduces the contamination risk, whereas the rigid IOLs will need a larger incision. Let's talk about the optic haptic angulation. Now, some IOLs incorporate an optic haptic angulation. Typically, this angle is about 5 to 10 degrees. Why is it so? Now, this angulation pushes the optic slightly posteriorly, improving the apposition with the posterior capsule and therefore reducing the potential space where the lens epithelial cells can proliferate, and thereby it lowers the risk of PCO. Now, non-angulated designs are commonly seen in single-piece IOLs, and angulated designs are commonly seen in the multi-piece IOLs. Now, there are certain lenses which also use an offset haptic design. What is it? Here, the haptics originate slightly behind the optic plane, and these designs, which are seen in TECNIS, may improve posterior clearance and enhance posterior capsular adhesion. Now let's move on to the optic edge design, an often underappreciated but extremely important factor in the intraocular lens performance, particularly in relation to the posterior capsular opacification or PCO. When we talk about the optic edge design in IOLs, we are referring specially to the shape of the posterior optic edge and not the anterior surface. The PCO does not occur randomly. After cataract surgery, the lens epithelial cells with the highest proliferative capacity are located at the equator of the capsular bag. Over time, these cells can migrate posteriorly and centrally along the posterior capsule. As they proliferate and transform, they encroach upon the visual axis, leading to the posterior capsular opacification. The optic edge here plays a crucial role. At the junction between the IOL optic and the posterior capsule, the edge of the optic induces a capsular bend. This bend acts as a mechanical barrier, interrupting the migration pathway of the cells towards the central posterior capsule. So the effectiveness of this barrier depends entirely on the edge geometry. We have two types of edge design mainly, the round edge design and the sharp or the square edge design. In the round edge design, as you can see, the posterior optic edge has a smooth curved transition between the anterior and the posterior surfaces. Because this design does not create a sharp capsular bend, the posterior capsule drapes smoothly over the optic edge. As a result, the equatorial lens epithelial cells are able to migrate freely behind the IOL and into the central visual axis. Clinically, this translates into higher rates of PCO and an increased need for the Nd:YAG laser capsulotomy. The round edge designs were common in early generation IOLs, but now largely they are obsolete due to their poor long-term capsular clarity. In contrast, the sharp or the square edge IOLs have a well-defined 90-degree posterior optic edge. This sharp posterior edge produces a tight capsular bend with a firm apposition between the posterior capsule and the optic. This configuration forms an effective mechanical barrier that prevents equatorial lens epithelial cells from crossing onto the central posterior capsule. Multiple clinical studies have demonstrated that the sharp posterior edge designs significantly reduce PCO rates. There's a lower need for Nd:YAG capsulotomy regardless of the IOL material. For this reason, a continuous 360 degrees sharp posterior edge is now considered the gold standard in modern IOL designs, especially in the premium intraocular lenses. Some modern IOLs incorporate a modified or a hybrid edge design. In these lenses, the posterior edge remains sharp to preserve the anti-PCO effect, while the anterior edge is rounded or sloped. The rationale behind this design is to reduce the photic phenomena such as the edge glare and halos, which can occur due to light diffraction from an excessively sharp anterior optic edge, particularly in patients with large pupil and high visual demands. So these hybrid designs aim to strike a balance, maintaining strong PCO prevention while also improving visual comfort and reducing the dysphotopsia. Okay, just a brief deroute. Let me tell you what exactly is diffraction and why do sharp edges cause glare. When light encounters a very sharp edge, it does not pass smoothly. Instead, it's going to spread sideways, and this is known as diffraction. This stray light reaches the retina outside the main image and causes photic phenomena such as the glare, halos, and edge streaks, especially in low light conditions or with large pupils. So by rounding or sloping the anterior edge, light transition becomes smoother and these symptoms are also reduced. So remember, round edges designs have the highest risk of PCO but minimal photic symptoms. Sharp edge designs offer the best protection against PCO but may increase dysphotopsia. Hybrid designs strike a balance. They maintain low PCO rates while reducing the glare and also halos. When we talk about the posterior capsular opacification prevention, it's not just about the posterior edge of the IOL. Several designs and surgical strategies work together to minimize equatorial lens epithelial cell migration. First, the IOL design features. We have already discussed about the edge design. Also, the haptics and positioning matters. In the back fixation keeps the optic centered, ensuring consistent contact with the posterior capsule. Optic haptic angulation vaults the optic slightly posteriorly, further reducing the space for the equatorial lens epithelial cell migration. Some premium IOLs have a native vaulting features, and even they have heparin coated surfaces which reduce inflammation and promote tighter capsular apposition. In materials, we discussed about the hydrophobic acrylic lenses, which preserves the sharp edge integrity and is more effective than the silicone and hydrophilic materials in preventing the PCO. Also, the heparin coated surfaces of these lenses might actually help in preventing the attraction and adhesion of the inflammatory cells onto the lens surface. Next are the surgical strategies. A continuous curvilinear capsular excess, slightly smaller than the optic, creates a shrink wrap effect, sequestering the optic and preventing the lens epithelial cell migration. Also, capsular polishing removes residual equatorial lens epithelial cells, reducing the stimulus for posterior capsule proliferation.